Warm greetings to all of you, dear Ayurveda students, faculty members and practitioners who are presently fighting with COVID-19 in this unforeseen scenario, and all the Ayurveda COVID warriors particularly. This is a lecture recorded for Ayurveda Network 𝘕𝐢𝑒, having titled COVID-19 Lung Events and Hypoxemia and Lung in Obese and Diabetics and Relevant Ayurveda Basics. This is part 1. Myself, Dr. Prasad Pandkar. I am a Pune-based Ayurvedic academician at 𝘉𝘦𝘵𝘠𝘕𝑒𝑚𝑑 University and Ayurveda practitioner. So what this lecture is about and what this is not about, this lecture do not include detailed Ayurvedic elaboration of pathophysiology of COVID. Well, it's been almost more than 1 year we are in these situations. And now it is normal for us that we all are treating COVID patients, and being a self-limiting disease, in most of the cases, it is not that challenging. What our challenge is only about hypoxemia and those with comorbidities, and particularly diabetics and obese patients, as they are affected more. So this lecture is not about Ayurvedic interpretation of COVID. It's again not about classically how 𝘉𝑚 is the phenomenon and the philosophy and elaborations and types of 𝘉𝑚. It's again not about how the classical Ayurvedic disease diagnostics is and how can you diagnose one COVID patient for 𝐾𝐜, one for 𝘉𝑚, and avastha-wise disease diagnostics will be different. We all are aware about that. This is again not something dealing with stage-wise managements and stage-wise prescriptions right from asymptomatic to post-COVID. This is not about. This lecture is particularly for our present challenge of hypoxemia. So to deal with that, we need to understand this pathophysiology of hypoxemia. So in this lecture, we will see COVID pathology, a quick review, then events in lung, the probable mechanism of hypoxemia, how a diabetic lung is different and what are the mechanisms going on there, how the things are dysregulated in an obese person's lung, how there is a crosstalk between lung and heart, lung and kidney, lung and gut, and how there can be probable Ayurvedic interpretations of all of these. And then, of course, we will be not talking about prescriptions, but few management pointers. So if you are interested in the how Ayurveda is associated, how COVID is interpreted in Ayurveda, here are a few publications. One by respected Ram Manohar Ji. He has published that monumental paper, Ayurvedic Dosha Profiling. One is by in Annals of Ayurvedic Medicine by Dr. Mahesh Sabde Ji, one more by me. So you can go through them. This lecture is about lung events, hypoxemia, and lung in diabetics, obese, and lung crosstalk. So let us take a quick review of COVID pathophysiology. We all are aware that this is all about immune dysregulation. If body's immune response is in its homeostatic way, then things will happen like they are shown here in green color. Patient may be asymptomatic or mild but can lead to recovery, or moderate but can lead to recovery. And if there is immune dysregulation, then there will be another prognosis. That is what is shown on this slide. This is again early stage and severe stage. This differentiation is very important because the early stage is stage of viral replication, where there is fever and few mild symptoms, upper respiratory or maybe even cough, and sinonasal symptoms. But when the virus reaches after 7 days to the lungs, then there is hyaline membrane formation and actual gaseous exchange gets disrupted, and that is why hypoxemia is there. So these two are different phenomenons, rather two stages of a phenomenon. And Ayurvedic practitioners or Ayurvedic researchers' job is a little more difficult He needs to understand all these mechanisms and then crossing the barriers of epistemology and terminology. He needs to interpret them in all. And probably the earlier presentation is Vata Kaphaj, but the latter stage with COVID pneumonia, it's something Pitta Kaphaj, Kapha Pittaj, and the stage of ARDS and multi-organ dysfunction syndrome, MODS, then that is certainly Vata Pittaj phenomenon. So we need to understand these steps and phenomenons accordingly. When it is evident that it is all about immune dysregulation, we need to understand that immune system is not just about those B cells and T cells and those antibodies, but on a larger picture, if we need to, if we see the whole picture of immune mechanism and how it is controlled, it can be something summarized like this, that there is a mutual control of nervous system and immune system. Immune mechanism controls nervous mechanism controls immune mechanism in turn. The major players are adipose tissue, leptin. Yes, there are publications, role of leptin in COVID. And then gut hormones, vagus nerve, and insulin resistance, that is emerging as a key factor, we all are aware. So these are the important players in immune control. And this is again from one paper from Nature, that how COVID and immunometabolism in type 2 diabetes or metabolic syndrome go hand in hand with each other. The problem how we all are dealing with COVID is we need to understand COVID as a syndrome rather. And this was already proposed here in this publication in Nature last year only. The author has put how things go, things have a great similitude. It can be like, say something, there are coagulopathies, then there are damage to the blood vessel and even nerves, or viral infection and inflammatory responses, or how that inflammatory component is there. So these are the similitudes between type 2 diabetes metabolic syndrome and COVID. So we need to understand COVID as a bigger picture, and after emerge of mucormycosis since last 1 month, it is quite evident that yes, there is a need to understand at bigger level. Then these are important investigations done in COVID. Neutrophil lymphocyte ratio or lymphocytopenia, lymphocytes get reduced. So that is nothing but altered defense. The probable Ayurvedic understanding can be, if lymphocytes are dealing with defense mechanism, obviously the probable Ayurvedic understanding can go with concept of bala, where Charaka says prakrutastu balam shleshma vikruto mala uchyate, and Susruta has quoted bala with ojas, equated bala with ojas. Then CRP, chronic inflammation, is again associated with C-reactive protein. The investigations that was already we people were doing in inflammatory conditions, autoimmunity, CVD, that was already associated with. A raised CRP can be understood like ama or rasadushti or raktadushti, or it is again being inflammation, it is associated with pitta, no doubt. LDH is the marker that indicates tissue damage, not only inflammation but tissue damage. So this tissue damage is associated with viscera guna of pitta. So this is about pitta and rakta. So kushnati vapu is the phenomenon that is mentioned in Kushtha. But Kushtha is certainly not only skin disease, but Kushtha is a bigger concept where all tissue degeneration or growth of tissue is happening. So that is the probable Ayurvedic translation, and Dushya Sangraha we need to incorporate. And yes, when we are speaking about Kushtha, Lasika is the prominent another Dushya, and Mucormycosis is upcoming complication there. Ferritin, that is again mediator of immune dysregulation. And so that is again Rakta, about Rakta and Pitta only. And elevated D-dimer, yes. This is the end product of fibrin mechanism. Elevated D-dimer levels indicate that yes, there is insult of that balance between coagulo and anticoagulo mechanisms, and some clots are continuously still being generated. So that is Kaphanobandhi Raktadushti. So these are the probable translations of investigations done in COVID. The whole disease diagnostics of COVID, it is 𝐴𝐴𝐴𝑚𝐴 followed by systemic involvement. You can call it 𝘔𝑚𝐴 Sannipata. See, it's not about calling so and so Sannipata by something by Wangasen or something by Bhavaprakash or something like that. It's never about nomenclature. It's always about understanding the pathology. So it is 𝐴𝐴𝐴𝑚𝐴 followed by systematic involvement. It is initial presentation is Vata Kafaj with Pitta Anubandha. This was very initially quoted by Ramanoharji. Yes, there is Anubandha of Pitta. Well before all these complications were evident, it was quoted. So as we have seen already, earlier presentation may be Vata Kafaj, but then there is at latter stage, it is Vata Pitta, and the stage of COVID pneumonia is that of Kapha and Pitta. Dushya are obviously rasa because Jwara is there. Things are starting with Jwara in most of the patients, although not all. Rakta is very important because Rakta Fena Prabhava Pupusaha, and coagulopathies are again associated with Rakta. So Rakta is the crux. Prano hi shonitam anuvartante. So for even hypoxemia, Rakta is the whole crux. OJS you need to incorporate as Dushya in COVID, because the whole thing is happening within a span of 15 days and people are dying within a span of 15 days. So OJS is indeed a Dushya, and you need to incorporate these things while management. Your kalpana should be Jivaniya, or your preparation should be Jivaniya. That is what the lesson here is, by incorporating OJS as Dushya. And then there is Shukra also as a Dushya, how we will see when we will see the lung events. Srotas, yes, Rasavaha, Pranavaha, Raktavaha, these are three primarily Srotas, and then many Srotas may be involved. It is Amashyottha Vyadhi, yes, Koshtha, Shakha are initial involvements, but latter involvements can be Tritiya Roga Marga, because Marma is there in Tritiya Roga Marga, Marmasti Sandhi. So Marma involvements, we are seeing so many patients, those are getting discharged after that heavy IPD session of say 15 days, 21 days. And after returning to home, they are dying with some cardiac complication, they are dying with MI. So Marma involvement and Marma Raksha is important, we are going to see it. This is guideline for newer diseases by Charka. Whatever newer diseases may come, you can just see the Vikara Prakriti. What was the Hetu, Adhisthana, which tissues are there, and Samutthan Vishesh, how the etiopathogenesis started and how it is going. That is what guidance given by Charaka, with which we all are interpreting COVID and facing with this pandemic. So to summarize, it's abnormal immune response because of Tridosha, Rakta and OJS abnormalities. Initial condition may be Vata Kafaj, but Pitta is important player. Alveolar damage, coagulopathies, both of about Rakta only, because Rakta Fena Prabhava Pusaha and coagulation of Rakta is again, blood is again associated with Rakta only. And this is what was proposed in the review paper I had wrote for JIM, that measures for conservation of Agni Bala, attainment of Rakta Pitta Prana homeostasis, and protection of three Marma should be important strategies. And yes, while practice, it is evident all of these three are important and they are the crux of whole COVID management. Conservation of Agni Bala, because prana is ultimately dependent on Agni. In homeo, this Rakta Pitta Prana homeostasis, yes, for hypoxemia and for oxygen saturations, this is the triad we need to concentrate and treat. Rakta Pitta Prana. And protection of 𝑔𝘪𝑚𝑦 is again very important. It's not just about something Kasa Shwasa. It is something starting with Jvara, having fatal complications, and ending with 𝑔𝘪𝑚𝑦 and Tritiya Roga Marga involvement. So that is the whole summary. Now let us move to lung events in COVID. So what are cells and secretions in the lung? Yes, there are three important cells. Pneumocyte 1, this is actually responsible for gaseous exchange. Pneumocyte 2, that is another cell. This is responsible for secretion of that fluid and you call as surfactant. And importantly, pneumocyte 2 serves as percussor for pneumocyte 1. And then there are alveolar macrophages, because lungs are they are exposed organ, exposed to the air. So that is why macrophages are there. There is a fluid, airway surface fluid. It's a thin layer fluid covering the luminal surface of airway epithelium. And this has got role in airway homeostasis. The regulation of this fluid, ASL, airway surface liquid, is important in lung defense. And then the maintenance of this adequate level of surfactant and balance of the two mechanisms, oxidative and antioxidative mechanisms in lung. These three phenomena are essential for adequate and proper gaseous exchange. So surfactant, this is secreted by type 2 pneumocytes. ASL was something different, that is just a liquid on your airways, but surfactant, it's a mixture of lipids and proteins. It is secreted by type 2 pneumocytes. Its main function is to lower the surface tension at the gaseous exchange interface. It also helps in keeping alveoli open and it facilitates gaseous exchange. So this is again very important along with ASL. And type 2 pneumocyte injury, this is already evident that type 2 pneumocyte injury reduces surface surfactant secretion, and this is associated with further reduction in lung compliance and can lead to atelectasis. So this is already reported in 2008 only. And why this is important? Because type 2 pneumocytes are the pneumocytes, those are primarily attacked by SARS-CoV-2. That's why it is important to understand this whole pathophysiology. When we are speaking about surfactant, this is again a beautiful thing that surfactant, although it is secreted by type 2 pneumocytes, but then there is a bigger picture and there is a role of hormonal accelerators. Yes, glucocorticosteroids, thyroxine, estrogen, these all are associated with the surfactant generation. So it is not just linear phenomenon that type 2 pneumocyte is secreting the surfactant, that is protein and lipid thing in your lungs, but the whole picture, the whole body picture, your immune mechanism and endocrino mechanism, they go hand in hand, and that is why these are the hormones, those are associated with pulmonary surfactant production. So in this way, we can see the picture at bigger level. So the respiratory infections doesn't only respiratory infections, but at a bigger picture level, we can understand them. And then there is another important component in lung, ACE2. We all are aware that ACE2 expression is there biggest at few places like your nasal epithelium or in lungs or in eyes. We all are going through all this literature these COVID days. And this ACE2 is again associated with angiotensin, the antioxidant mechanism, as well as it is associated with renin-angiotensin mechanism. So that is why kidney and lung, the whole interplay goes on. And ACE2 expression is higher in type 2 pneumocytes than in type 1 pneumocytes. This is again the thing why type 2 pneumocytes are affected by SARS-CoV-2, because we all are aware that ACE2 is the receptor for SARS-CoV-2 virus. So these are the important players in lung. What are they? Type 1 pneumocyte for gaseous exchange, type 2 pneumocyte that produces your surfactant and that serves as percussor for type 1 pneumocyte, then alveolar macrophages, and then the fluid we saw, ASL, airway surface liquid, and these ACE2. Now with these players, let us try to understand what happens in a COVID lung. The phenomenons are DAD, this is hallmark of COVID lung pathology, diffuse alveolar damage, hyaline membrane formation. Yes, this is part and parcel of DAD only, but it is important to mention as a separate phenomenon because this is why gaseous exchange becomes difficult and hypoxemia is there. Alveolar condensation and then ground glass opacities we all know, and along with this all, there is vasculitis and there are coagulopathies. So let us understand these things. DAD, this is hallmark of COVID pathology. Diffuse alveolar damage. Yes, diffuse is diffuse. Alveolar is, it's not about airway, but it's about alveolus. So it is damaging alveolus, and particularly what? Particularly type 2 pneumocytes. So that is why hyperplasia will occur. Along with that, DAD, there will be presence of multinucleated pneumocytes, fibrogranulation, tissue proliferation in small airways and air sacs is seen. Some studies report capillary injury as well as mural and luminal fibrin deposition. And macrophages and neutrophils, all these, they get infiltrated in septa. So that is what DAD is. HMD also occurs when there is not enough substance, that is called as surfactant. So we have seen these basics. When there is no enough surfactant, the tiny alveoli collapse with each breath you take. And that is why DAD, that was already there in interstitial lung diseases, or even earlier viral lung infections, DAD was earlier there. So this is the classical phenomenon, DAD. What are steps of DAD? Diffuse alveolar damage. There are 3 steps, and these 3 steps get ignited with the insult. The insult is viral invasion. What are 3 steps? Exudative, proliferative, and then fibrotic. First phase is exudative. Neutrophils and macrophage recruitment happens there. Epithelial lining gets damaged, and then it allows plasma and protein to leak into airspace. So the airspace lining gets damaged, and now plasma and proteins are there coming in, and then there is limited ability to pump this edema out of airspace. And then this edema contributes to the deposition of hyaline membrane. It is composed of dead cells, surfactant and proteins, and at alveolar walls. And this hyaline membrane is the characteristic of DAD, and because of this membrane, the gaseous exchange gets affected. The edema also interferes with surfactant. So this is the first phase. There is an image in upcoming slide. With that image, it is again explained very good manner. After this exudative phase, if immune response is good or the treatment is given appropriately, the things will land up in next stage, that is proliferative. Yes, there will be recovery. the epithelial lining will be repopulated with pneumocyte 2. And then there will be critical task of transporting edema out of air spaces and back to the interstitium, and macrophages will be clearing all the cellular debris. So that line will again be reabsorbed and there will be repopulation of pneumocyte 2. All this debris will be cleared and all that plasma has came into leaked into air spaces will be removed. This is phase 2 with proper treatment or proper immune response, whatever it may be. And last stage that is not seen in all, but that stage is fibrotic. This will happen if the alveolar collagen that is deposited during the exudative phase fails to be reabsorbed. If that is not reabsorbed, it will remain there and this will lead to fibrotic lungs. We are seeing this phenomenon that is very difficult to treat. 𝐷𝘠𝘵𝘀 or 𝑉𝑖krānta are drug of choice there. But once things go in fibrotic phase, it all becomes difficult. And due to this, gaseous exchange is going to be difficult. So these are the 3 steps in DAD: exudative, proliferative, and fibrotic. Yes, this was the figure I was talking about. On left side, you can see the initial or the normal alveolus where there is, this is the type 2 pneumocyte and this is type 1 pneumocyte. It is seen here. And then there is alveolar macrophage. And yes, the interstitium is seen. And how this gaseous exchange is going on, that can be seen on the left side. And what happens in injured alveolus, yes, it can be seen here. First and foremost thing, yes, the plasma has leaked into inside. Cytokine storm is there. Type 2 cells are affected there. Hyaline membrane, this orange or this red color they have shown here, is formed here, and that is why gaseous exchange is not happening properly. So this phase of COVID pneumonia, this is kapha-pitta phenomenon because the edematous component has entered into airway. So that is why kapha is the player here. And this is happening with all inflammatory markers, raised inflammatory markers. So this is essentially kapha-pitta phenomenon. And afterwards, when the vitals get involved and patient will land up in MODS, multi-organ dysfunction syndrome, then it will be vata-pitta. But this COVID pneumonia stage, this is kapha-pitta. Of course, it is 3 doshas. Everything is 3 doshas. Now, this type 2 damage, we understood there are 3 cells, type 1 pneumocyte, type 2 pneumocyte, and alveolar macrophages. And SARS-CoV-2 is affecting pneumocyte 2. How to understand this in Ayurvedic perspective? The first and foremost thing is Rakta Fena Prabhava Pupusaha. So, like bubbles get formed in a similar way, it is Rakta, and then there is phenomenon of Fenibhutatva. Fena comes into picture and the air sacs gets formed. That is what says Ayurvedic embryology. So the alveolus is made up of Rakta and the airway is nothing but Vayu and Akash Mahabhut. So that is what the basic thing is. Now coming to pneumocyte type 2. Ayurveda has not mentioned type 1 pneumocyte, type 2 pneumocyte, but Ayurveda has mentioned things in their karmanumeya way. Concept of dosh dhatu bala is less structural, more functional. Ayurveda prefers to understood things at the level of gunas and at the level of karma. So although type 2 pneumocyte is not mentioned in Ayurveda, but we can understand type 2 pneumocyte with its functions. And what are functions of type 2 pneumocyte that is getting affected by SARS-CoV-2? The functions are, this pneumocyte 2 serves as precursor for pneumocyte 1, which simply means type 2 pneumocyte is the Shukra Dhatu. Type 2 pneumocyte is the crux on which regenerative component, the regenerative efficacy of lung is going to depend upon. And also, type 2 pneumocyte is for generation of surfactant. So although it is not like this is equal to this, but Prakrit Kaf Nirmiti is what type 2 pneumocyte is associated with. And when type 1 pneumocyte gets damaged, type 2 pneumocyte is acting as a percussor for type 1 pneumocyte. This simply means that type 2 pneumocyte is associated with Oja, Bala and Shukra. Saptami Shukra Dhara Namaya Sarva Sharira Vyapini. Ayurvedic concept of Shukra is not associated with only that semen or that some reproductive system, but Saptami Shukra Dhara Kara is there everywhere. It's there everywhere. And type 2 pneumocyte, which is percussor for type 1 pneumocyte, is affected by SARS-CoV-2. Is nothing but SARS-CoV-2 is affecting the regenerative component of the lungs. The Saptami Shukradhara that is placed in lungs, that is getting affected, and that is why Rasayana medication is very important. Rasayana medication is very important. In Ayurvedic Chikitsa, this is a beautiful concept that things can be Vyadhihara, at the same time they can be Rasayana. So whenever you are prescribing, it is very essential that your medicine is should be Rasayana. It can be ST, it can be Pipali, it can be Guduchi. All these things are Rasayana. And then there are things which are not Rasayana. Say Dhamasa. Dhamasa is of great help in reducing the D-dimer and like things. Because Patha and Dhamasa are the things, those act on Grathita Tattva. But Patha and Dhamasa are not Rasayana. I was associated with a few formulation developments, and when we came to nomenclature, we nomenclated it with the suffix of Rasayana, with the prefix of Rasayana. So Rasayana is very important because SARS-CoV-2 is affecting regenerative component of lung. Hyaline membrane formation, how to understand this? Yes, this is Avarodha. Avarodha is essentially by cough. So no doubt it is Avarodha is by cough, but it is not the case that every time Avarodha is because of cough. In so many COVID patients, we need to understand that even Vata subtypes can obstruct each other. So whenever a phenomenon of obstructing is there, it is not necessarily every time to be done by kapha, but Vata subtypes can get obstructed with each other. And then we need to go through the whole Charak Vatvyadhi Chikitsa and Vatrakta Chikitsa of Vakbhat to understand the Anyonya Avarana, and then which are the group of symptoms, and we need to cross-check them in our COVID patient. So Shwasa Samrodha is not only about Kasa Shwasa Urakshata. It's not limited to that. The important Adhikarana here, along with Jwara Kasa Shwasa Urakshata, is Vata Vyadhi also. And these are the verses where you can find dysregulated immunity and dysregulated respiration in Vata Vyadhi chapter. Avarana of Vyanabai Prana, there is Smriti Balakshayam. Then Avarana of Udanabai Prana, last one, Balavarnanam Nashu. So immune mechanism getting altered is needed to be seen in Vata Vyadhi chapter also. And if you see the middle shloka, this is very important. Avarana of Udanabai Prana, the symptoms are Shirograha, Pratishaya, Nichvasa, Uchvasa, Sangraha, Rudrogo, Mukhashosha. And Chikitsa is Tatra Urdhvagi Karmam, Karyam Ashvasanam Tatha. Ashvasanam is very important. We all are working with COVID and we all know how Ashvasanam is important. So it's not just Jwara, Kasa Shwasa, but equally important Vatvyadhi also. And let us summarize the Dosh Dhatu Malayan respiration, because that is the thing on which your management is going to depend upon. Raktafena Prabhava Pupusaha, Kafashonita Prasad Dilip. It's Avalambak Kaf on which Bala is dependent. That is getting here dysregulated immune mechanism, Bala. Prana Gati is upward as well as downward. This is the beauty with Prana. Prana has few functions denoting upward gati and few functions denoting downward gati. The Purana is because of downward gati, but few other things are associated with upward gati. Udana is associated with only urdhva gati. That is why Udana is against gravity, and that is why Udana is associated with Bala also. And Vyana has all the three gatis. And yes, you need to have Samana everywhere, because Sama ignition of Agni, and keeping things Sama is what Samikaroti iti Samana. So there are all of 5 Vayus are there in mechanism of respiration. If Prana is important because dilatation is associated with Prana, because Purana is function of Prana, and for Purana you need to have dilatation. So may it be bronchodilation, may it be vasodilatation, may it be your dilatation of your any body channel or any body tunnel, any structure that is essentially associated with Prana, and that dilatation is proper only if your Agni is proper. And that is why Upanishada Pranas are flooded with the references that Prana is dependent on Agni. What is their essence? Prana is dependent. Agni means if Agni is at optimum level, Srutasas will be dilated in their appropriate manner. And if Srutasas are dilated in their appropriate manner, then and then only Purana can happen. So this dilatation is because of Prana, constriction because of Udana and Vyana, and yes, there is role of Apana. Charak Siddhi 9, Tatra Hridaya Dashadamanya Prana Panav. So Dharana, Apana is about Dharana. So Dharana of that air for few microseconds or seconds is because of Apana. And yes, we are seeing in this in dealing with COVID patients, there are few patients, those are having constipation. If you just give them Erindale, castor oil, you will see the results on next day. And yes, those with Grahani, you need to give Lagusutchakar or something. There are few patients, those complete weakness after having Apana activity, after coming to from defecation, defecation के बाद मुझे थोड़ा सा कुछ तो liquid वगैरह लेने की इच्छा होती है. So in these places, the dharana component is affected. And in those constipated, you just give Erindale and you will find oxygen levels elevated. There are patients who are having bowel is not cleared since 4 or 5 days. There is no body activity. Patient is admitted since 14-15 days. So if the constipation history is already there, castor oil is the drug of choice. Anyways, we will be not going into that. We will be keeping to pathophysiological framework. So COVID-19, it's essentially primarily alveolar disease, because lung disease pathology is classified into 2. Lung diseases are either alveolar or airway disease. So they are also said as restrictive and obstructive diseases. So gentlemen, it is pretty clear that SARS-CoV-2 is affecting your alveolus. So it's not airway disease. We all have worked and we all know that there are no secretions and then there are no aspirations and that glass bottle machine and everything that is not seen in COVID ward, because there is nothing to aspirate. It's not about airway, but about damaging the alveolus itself. And if we see the Charaka Shvasa Chikitsa, we come to understand that there is a verse at the end of Shvasa Chikitsa, 𝐻𝐾𝐿 kaphavatagam ushnam vatanulomanam. All that is kaphavatagna, ushna and vatanulomana, this is the verse that probably speaks for airway diseases. Whereas for alveolus, Charaka is mentioning Sarvesham Bruhanaiya Alpaihi. Or Charaka further mentions, if Shamana Natyartam Shamano Apaya, if you do excess of Shamana, there will be no Apaya. But if you go for Karshana, yes, there can be chances of complication. And that is why, like he has quoted in Kshayaja and Kshatrashakas, and even if in Gulma, that Deepana Bruhana, give alternatively. Here also Charaka is mentioning for Sarvesha Bruhanahi Alpaihi. Little, thoda sa, 𝑎ल्पबृहन्. Why? This is for alveolus. And 𝑘𝐴𝐴𝑡𝐻𝑚 that is for the airway disease. So here alveolus is getting affected. So we need to understand the thing that there is a need of Bruhan. Of course, in acute phase, you are not going to go with Bruhan, but your medicine has to be assigned. That is what we were talking about. Now just understand the pathophysiology of hypoxemia, and we'll conclude with this part 1. Hypoxemia. We know all these terms, hypoxemia, hypoxia. What are the causes and mechanism of hypoxemia? There are few papers those deal with this. I have tried to compile, and yes, the intrapulmonary shunting is the first cause, and that is why there are few pediatricians who have wrote for this intrapulmonary shunting is the mechanism, and that's why pediatricians have wrote papers on hypoxemia and its mechanism in COVID. So the causes and mechanism is intrapulmonary shunting, phenomenon number 1. Loss of lung perfusion regulation, that is phenomenon 2. Third is intravascular microthrombus. And last is impaired diffusion capacity. These 4 components result into hypoxemia. Let us see one by one. Intrapulmonary shunting. Yes, we all know this is a VQ. V is ventilation, the air we breathe in. Q stands for perfusion, the air that gets perfused in the blood flow. And the physiologically, it is 4 liters of air when it enters in the respiratory tract, but there is almost 5 liters of blood that is going through the capillaries. So the ratio is 0.8, 1:0.8. And this VQ maintenance is essential, and this VQ mismatch is the important cause of hypoxemia. Hypoxemia in COVID-19 is resultant of VQ mismatch because of vascular pathology, especially in early stages. Loss of hypoxic pulmonary vasoregulation is attributed as a mechanism. Nobody knows what mechanism is, but all the pathophysiology people, they are putting hypoxic pulmonary vasoconstriction. This is a physiological phenomenon, and with viral insult, this phenomenon gets lost. What is the phenomenon? The phenomenon is hypoxic pulmonary vasoconstriction. It is a reflex contraction of vascular smooth muscles of pulmonary secretion, and that is needed for regulation of the perfusion and ventilation. And this physiological reflex gets lost due to the viral invasion or viral insult. Maury et al. Demonstrated that ventilation perfusion mismatch with larger prevalence of ventilated non-perfused lung units that we call as dead spaces in comparison with perfused one that we call as shunts. Then there is a local interstitial edema, particularly located at interface between lung structures with different elastic properties. The shear stress in lungs, we know the physiology of where the shear stress and strain are concentrated particularly. Also increased lung edema that will lead to ground glass opacities, and also loss of surfactant and superimposed pressure and alveolar collapses. They all lead to the result in the intrapulmonary shunting. So shunting is the first phenomenon. Second phenomenon is loss of lung perfusion regulation. The air that is taken into that is needed to be perfused in blood. So how that regulation is getting disturbed? Number 1, the steps, 3 steps are here. Release of endogenous vasodilators. It can be prostaglandins, bradykinins, or cytokines associated with inflammatory process or by yet another unknown mechanism. So vasodilators are coming into picture, and at the same time related failure of hypoxic vasoconstriction. So that is what we already said. So there are two things happening. Vasoconstriction reflex is getting deregulated, and at the same time this cytokine storm is leading to dilatation. So obviously there will be perfusion regulation will be lost. And the last phenomenon here mentioned is the persistence of high pulmonary blood flow to the non-aerated lung alveoli, and vasoplegia seems to be influential in the loss of lung perfusion regulation, possibly induced by shear stress. So shear stress is there, vasodilatation is there, and vasoconstriction physiological reflex is getting altered. So that was about second. We understood first one, shunting. Second was lung perfusion regulation is getting lost. It is intravascular microthrombus. This is very important because endothelial injury is emerging as a central hallmark of COVID-19 pathogenesis. So it's not just LRTI, URTI. It's endothelial injury as hallmark. So this is already known that intravascular microthrombus is a result of imbalance between procoagulant and electrolytic balance. DIC is also seen in few of the patients. Then it was found in autopsy of many COVID lungs that there was fibrin deposition. Along with DAD, there was vascular thickening and microthrombus were seen. Even large thrombus were seen there. And this hypercoagulable state leads to the further deterioration in the 𝑉𝑞 mismatch and more lung tissue damage. So coagulative component, it's not only about some pulmonary embolism or something, some leading to fatal thing, but this hypercoagulable stage is again leading to 𝑉𝑞 mismatch and further lung tissue damage. Also, there is one important thing. Moreover, coagulation is also modulated by activating CRP, ensuing complement activation and hepatic synthesis of fibrinogen as an acute phase protein. So intravascular microthrombus, this is a figure here. We all are already known. I'm just repeating or summarizing or briefing things here, that cytokine storm here within alveolus, and here platelet aggregation and how the clot is there, and with proper treatment these things can be dissolved. Impaired diffusion capacity, this is the last phenomenon. For diffusion you need the proper the whole alveolus, and SARS-CoV-2 propagates with alveolar type 2 cells followed by immune response mediated destruction of infected cells. So obviously if the cells only are less in number, obviously diffusion capacity will be less. There are reports that there is decreased DLCO, diffusing lung carbon monoxide, in COVID-19 patients at the time of discharge. So they are indicating again that impaired diffusion capacity only, because the tissue itself is getting affected. As I said earlier, it's not airway disease, it is the alveolar disease. This is a very basic classification of lung diseases. Ayurveda physicians need to understand that restrictive versus obstructive, or COPD versus alveolar disease. So it's alveolar disease, and yes, the prevalence of impaired diffusing capacity was linked with severity of disease. So and so percent in mild, so and so percent in COVID pneumonia, and so with severe presentations. So these are the four mechanisms, and we need to understand them very well. First was intrapulmonary shunting. So if shunting is the phenomenon, Rakta Prasadana needs to be your thought line while managing COVID pneumonia. Because prana is shonitam anvartante. If shonita is good, then and then only prana will be good. The tika on this verse, prana is shonitam anvartante, is very beautiful, where they have mentioned that If there is prana, there is rakta. If there is no rakta, if there is rakta, there has to be prana. That is how the relationship is. So Rakta Prasadana is your one important thought and mechanism pointer. Loss of lung perfusion regulation. This lung perfusion regulation lost is because of few pathologies you need to understand. And for that you need to remove the edema component first. And in Ayurvedic concept of Shotha, the Dusha, Tridosha, Rakta and Sira again. So things are again coming to Sira and Rakta. So things are again coming to Rakta because Sira is again Upadhatu of Rakta only. So lung perfusion regulation is again, we just saw how Panchavayu are associated with respiration and altered respiration. So the Purana is because of Prana. Purana is because of Prana. And when perfusion regulation is lost, it's essentially Prana Vikruti. And then we have already seen that it is not just Kasa Shwasa, but it is Vata Vyadhi also. We need to understand these Adhikarana very well. Kasa, the Samprapti of Kasa is Adhapratihato Vayu. The etiopathogenesis of Kasa is Adhapratihato Vayu. So Anuloman of Prana and Adhapratihato of Vayu is the central phenomenon in Ayurvedic concept of Kasa. Whereas Ayurvedic concept of Shwasa is little different. If we see Charak Chikitsa 17, it's Pitta Sthana Samudbhava. Kaphavadaatmakau, but Pitta Sthana Samudbhava. So that is the difference between Kasa and Shwasa. So Shwasa is Pitta Sthana Samudbhava also. And here we see distinctly Pitta Rakta Dushti. So, and it's not just Kasa Shwasa as I have already quoted, but it can be Anyonya Avarana also. So this lung perfusion regulation, you need to be seen associated with Anyonya Avarana also, and that is why 𝘠𝑚𝑗𝑛𝐴 Chintamani is helping. If your patient is lying down in ICU for say 20 days, 21 days, or your patient is discharged with oxygen cylinder, then that is a Vyadhi Karshita patient. And then there is more role of Vata Vyadhi. And 𝘠𝑚𝑗𝑛𝐴 Chintamani is seen helping the patients. Next phenomenon is intravascular microthrombus. So it's not just stenting, it's not just perfusion lost, but it's the thrombus accumulating. So what that is Rakta Pitta with Kaphanubandha, and that clot is essentially because of kapha, but at the same time vasculitis, which is again very central to the COVID lung pathology, that itis is because of pitta, because paka is the karma of Vikrit Pitta. So the picture here is Pitta Kafash, and that is why Patha Damasa, that is in Maharashtrian tradition, or only Damasa, because Damasa Pitta Shleshma Prashamananam Sreshtaha, quotes Charaka. So Damasa font is seen to be prescribed by so many physicians when elevated D-dimer is there. And at last, it's impaired diffuse capacity. The alveolus itself is less than what physiologically should be in the quantum. So it is avayava kshaya. Your alveolus are less only. So you need to regenerate that alveolus component, all the cells, pneumocyte 1 and pneumocyte 2 that are required for lung function. You need to regenerate them very fast. And for any regeneration in Ayurvedic concept, you need Rasa, Rakta, Shukra and Agni. Because Rasa is there for all dhatus. Poshana is dependent on Rasa only. Rakta, yes, Tesham Dhatunam 𝘔𝑎 𝑣𝑟ද්ධि quotes Charaka, Susruta, sorry. And Shukra, as we have already seen, it's about regenerating lung tissue. And it's not only about dhatus, but only if Agni is there, only if proper Agni is there, the repopulation of lung epithelium, lung tissue, the alveolar tissue is possible. So these are the possible thoughts Forget translation. Translation is very big thing. I have merely put the possible thoughts on in first phase on lung events, and in this second phase on hypoxemia in COVID and its mechanisms and possible Ayurvedic thoughts. And this is the last slide. When we are dealing with hypoxemia patient, these are the Sharir factors. Those are must in our thought process. Yes, it's a Kaphasthana Ura, and players are Vayu and Pitta. That is why Kaphasthana Purvavya. You need to do Chikitsa of Sthana. And that is why in South Indian tradition, they are using 𝘔𝘪𝘶𝘐𝑢𝑟𝑛𝑎𝑚 in earlier stage. Because you need to treat Kapha only, because it is Sthana of Kapha, although the players are Vayu. Because this 𝘔𝘪𝘶𝑢𝑟𝑛𝑎𝑚 comes from Amashagatavata. So these are the lung events where Kapha Sthana is there. That is the Sthana of Kapha, but players are Vayu and Pitta. When we are talking about lung events, yes, there is one arm in Mahasrotas, because Pranavanam Srotasam Hridayamulam Mahasrotasya. That is what I was referring to. If Agni is good, then and then only all body channels, they will be properly dilated. Not only alveolus, not only airway, but the vessels, all the tubular structures, the fallopian tube, each and every body tubular structure. Dilatation of that structure is associated with Agni, and constriction of that structure is associated with Udana. Because for constriction you need Bala. That's why constriction is associated with Udana, and for dilatation you need Agni, because dilatation is with about Prana and function of Prana is Purana. So it's Kaphasthana, and another arm was there in Mahasrotas. And yes, when Rakta is the thing, or Prano Ishwanitam Anuvartante, you cannot separate out Rakta as a separate entity, but there is a triad of Pitta, Rakta and Sweda. Because Pitta and Sweda are associated with Rakta in their physiological and pathological frameworks. So your management should be according to that also. You also need to consider that Prana is there in Shira as well as Ura. And yes, that is what is seen today, the cardiac complications. Few are reported in neural complications. Neural complications are seen more in overseas, but Indian population, there are less reports about neural complications in COVID. And yes, when we are dealing about hypoxemia, it's not just Prana and Rakta, but Oj also. Because it's all about altered immune response, and altered immune response is about Bala. Because Balakshaya and Mrityu, that is happening within 14 days. Hypoxemia is just one mechanism in between. Patient is landing up into death. So Bala, Ojas, Prakrut Kaf, and Manobala, these are again important components. So this is the Sharir in hypoxemia. You need to understand before you prescribe of COVID pneumonia. So thank you all. This was the end of part 1, where we spoke about COVID pathophysiology in brief. Then we saw lung events happening. We understood how the DAD comes into picture, diffuse alveolar damage. We also saw the lung cells and lung secretions, and which of the lung cell is getting affected. And then we understood the possible mechanism of hypoxemia and its Ayurvedic counterparts. So this was end of part 1. In part 2, we will see how a lung in obese person is unique, how the lung pathophysiology is different in a diabetic person, and how the lung is having its crosstalk with another vital organs. And then we will summarize the things. Thank you.